I will present the role of dermatologic manifestations as a predictive value on CD4 cell count among HIV/AIDS patients. As we have already been familiar with HIV, it belongs to the Retroviridae family, is an RNA virus, and the most common transmission is through sexual contact, maternal-infant exposure, and shared needles. To date, up to July 2022, the World Health Organization stated current HIV epidemic estimated to be 38.4 million people live with HIV worldwide in 2021. Once infected with HIV, it will target the CD4 cell and multiply. First, it binds through CD4 receptor CXCR4 or CCR5, and then fusions will allow HIV to enter the CD4 cell and release its RNA and enzymes. HIV then uses a reverse transcriptase to convert its genetic material from RNA and DNA to enter the nucleus. Inside the host CD4 cell nucleus, it releases integrase to insert its viral DNA into host cell DNA. HIV uses CD4 cell as their building block protein chains for more new HIV. New HIV RNA will move to the surface as immature or non-infectious HIV virus. Lastly, it's budding out of its immature new HIV from the host cell from the CD4, then release protease and become mature or infectious virus. As this life cycle will repeat, as the CD4 cell is the targeted cell of HIV, the infected CD4 cell will then be destroyed. HIV life cycle repeat and more healthy CD4 cells invaded and destroyed by HIV, hence resulting in a continuous loss of CD4 cells. The skin, on the other hand, is an organ equipped with a capacity to mount and execute immune response. The number of T cells in the skin is nearly twice as many as that in the peripheral blood. Skin T cells play a critical defensive role against skin infection and other pathological conditions. These are the various subsets of CD4 in humans. CD4 cells, predominantly known as helper cells, they provide help by producing cytokines to fight against invading pathogens. Each subset is associated with different chemokines and cytokines, which each of these contribute to cells' ability to respond in the range of different skin diseases. The progression of HIV is marked with a decrease of CD4 cell count and increase in viral load. Then, according to the literature, dermatologic manifestation may occur any time of the infection with a prevalence rate of more than 90%. Dermatologic manifestation in HIV usually more severe, atypical, widespread, and recalcitrant, sometimes making the diagnosis and treatment often challenging. Many similar studies were done in India, South Africa, Iran, Nigeria, Mauritania, and Korea or China, but studies in Indonesia were done only in major cities such as Surabaya, Manado, Yogyakarta, or Medan. Palembang is a smaller city in South Sumatra, Indonesia, which represents a more conservative population with low awareness, high stigmatization, and skepticism towards HIV/AIDS. Dermatologic manifestations may be the first sign of HIV and postulated may predict the immune status of the patient. As with previous study, it will classify into three groups: the infection group, the non-infection, and the combination. Previous study shows it was infection group is associated with low CD4 cell count, while others state the contrary. Hence, our study aimed to determine the positive predictive value and negative predictive value as the primary outcome of the study, also to determine the prevalence and variety dermatologic manifestations among HIV/AIDS patients. This was a cross-sectional observational analytical study with a population of patients with HIV in the outpatient clinic of Dr. Muhammad Hussein General Hospital. Sample population was determined for a population with 95% confidence interval estimated to be 80 from December 2018 to March 2019, and the study was approved by the board's ethical committee. Inclusion criteria was patients more than or equal to 18 years old with HIV, with or without ARV treatment, willing to cooperate for the study. Demographic data were collected, and dermatologic examinations were done if necessary. Then, dermatologic manifestations were recorded and categorized into infection, non-infection, or combination. Blood examination were done to evaluate CD4 cell count, and the study was analyzed. For the result, we had 83 eligible HIV/AIDS patients with mean age of 34 years old. The most common age group was 30 to 39 years old, where majority were male, with male to female ratio is 4.5 to 1. More than half claiming having a bisexual behaviors, with most of them were underweight and having a low CD4 cell count or less than 200. The prevalence of dermatologic manifestations was 84.3%. From a total of 83 eligible patients, 70 had dermatologic manifestation, while 13 had none. Among the 70 patients, 45 of them had CD4 cell count less than 200, and 24 of them had CD4 cell count between 200 to 499. The most common dermatologic manifestation among CD4 cell count less than 200 is combination, followed by infection and non-infection. While in CD4 cell count 200 to 499 cells, the most common is non-infection, followed by the others. And among the patients who had no dermatologic manifestation, 7 of them had CD4 cell count more than or equal to 500 cells, while 6 of them having 200 to 499 cells. These are the list of infection dermatologic manifestation, with highest is the oropharyngeal candidiasis, followed by herpes zoster reactivation and dermatophytes. These are the list of disease for non-infection dermatologic manifestation, with the highest is the seborrheic dermatitis. This is the list of the combination dermatologic manifestation, with the highest case was the oropharyngeal candidiasis with seborrheic dermatitis. There was a significant association between dermatologic manifestation with CD4 cell count less than 200, with a prevalence ratio of 3.944, with P less than equals to 0.001. There was also a significant association between the number of dermatologic manifestations with CD4 cell count among HIV/AIDS patients with P less than or equal to 0.001. Infection and combination group manifestation had 97.8% of positive predictive value of having CD4 cell count less than 200 cells. Non-infection or no dermatologic manifestations had 31.6 negative predictive value of having a CD4 cell count more than 200. Another calculation of PPV and NPV based off the population prevalence with 90% and specificity and sensitivity is even higher of having 98.4% PPV having a CD4 cell count less than 200. For the discussion, our study show majority were male. This was in concordance with another study by Pujati et al. And the literature. Although we had slightly higher male to female ratio, majority of our patients had low BMI. This was also in concordance with the literature and other study by Hugh et al., which explains that the malabsorption of nutrition from diarrhea along with low intake as the main cause of the malnutrition. We had 84.3% of the prevalence having dermatologic manifestation, slightly lower than the literature, but in concordance with other studies by Neti, Pujati, and Malkut et al. Okay, the most common dermatologic manifestation with CD4 cell count less than 200 is the combination. This was in concordance with the study by Malkut, Vasudevan, and Chauhan. All of them characterized with more than one dermatologic manifestation. Study by Premanadam and Devi et al. Also reported that severe, extensive, recurrent, and treatment-resistant seborrheic dermatitis is not, and other opportunistic infection is not only a dermatological marker of disease, but an indicator of disease progression. The second most common dermatologic manifestation in patients with CD4 cell count less than 200 is infection. Our result was in concordance with, but slightly higher than other study by Vasudevan, Chauhan, and Malkut et al. This was due to decrease in CD4 cell count induced lower immune response, hence harboring skin at a condition prone to infection environment, especially opportunistic infection with moderate to severe clinical manifestation. Among infection group, oropharyngeal candidiasis is the most common dermatologic manifestation. This was in concordance with study by Chandrakala and Malkut et al. A study by Fidel et al. Explained that there was an altered natural flora in HIV/AIDS patients, which heightened the risk of opportunistic infections, while a more extensive distribution up to the pharyngeal is due to the decrease in protein moiety annexin A1 to inhibit Candida species. The second most common disease in the infection group was the reactivation of herpes zoster. Who et al. Reported that HIV/AIDS patients have 3 to 20 times higher risk of herpes zoster reactivation than a non-infected individuals. All 4 of our patients were male with CD4 cell count less than 200 cells per microliter. This was in concordance with Ku et al. That reported male and low CD4 cell count was a significant risk factors for herpes zoster reactivation in HIV patients. All 4 of our patients also had bilateral cervical lesions. Among them have disseminated zoster. Cervical dermatome was the Vora et al. Also reported that cervical dermatome was the commonly involved dermatome in HIV patients. Akimoto et al. Explained that a more widespread bilateral distribution in HIV patients was due to more ganglion affected from diffusion and spread of virus. The most common dermatologic manifestation in patients with CD4 cell count 200 to 499 is non-infection group. This was in concordance with a study by Rain, Lahoti, Neti, and Pujaty. And among the non-infection group, there is a seborrheic dermatitis was the most common dermatologic manifestation. Desionote et al. Explained that there was an increased risk of transformation of normal flora into its pathogenic form, where its pathogenic form will continue to disrupt and produce pro-inflammatory cytokines, giving a recalcitrant seborrheic dermatitis among HIV patients. Also, Zaid et al. Reported that a healthy individual with seborrheic dermatitis may carry even a 10% risk of having an undetected HIV infection. Having CD4 cell counts more than 500 cells is associated with non-infection and no dermatologic manifestation. Boshab and Freeman et al. Reported that there was a dysregulation of immune system homeostasis, which explained higher CD4 cell count associated with non-infection or no dermatologic manifestation. Reinhardt and Neti et al. Also reported that a progressive decline in CD4 cell count increased the incidence of AIDS-defining illness, especially with CD4 cell count less than 200 cells. The result of this study showed a statistically significant result of CD4 cell count with dermatologic manifestation, that lower cell count, less than 200, is associated with infection and combination, while the CD4 cell count 200 to 499 is associated with non-infection group, and CD4 cell count more than 500% associated with non-infection and no dermatologic manifestation. This was in concordance with other study that stated lower CD4 cell count increased the risk of occurring of dermatologic manifestation. This study found HIV/AIDS patients with lower CD4 cell count had an increased risk by 3.944 times of having dermatologic manifestations with a prevalence ratio of 3. This was slightly higher than the previous study by Pujaty et al. This study positive predictive value refers to the likelihood of the patients with infection and combination dermatologic manifestation having CD4 cell count less than 200. In contrary, the negative predictive value refers to the likelihood of patient with non-infection or no dermatologic manifestation having CD4 cell count more than 200. Our result is slightly higher than the previous study by Levy et al., who reported HIV-related oral lesions that have 75% PPV of finding CD4 cell count less than 200. The limitation of our study is a small population study and the diagnosis was made majorly based on clinical diagnosis with simple dermatologic examinations. Treatment of ARV was not homogeneous, and CD4 cell count, we are aware that CD4 cell count was not the only variable to determine the strength of deterioration among HIV/AIDS patients. We recommend further studies with larger population study along with variable examination. I will show some of my patients as we have a documentation. These are erythema multiforme with a secondary syphilis in a new HIV patient. This is a condyloma acuminate, severe seborrheic dermatitis with molluscum and oropharyngeal candidiasis. This is a papillary pruritic eruption and cirrhosis patient. Papillary pruritic eruption and seborrheic dermatitis and oropharyngeal candidiasis. Papillary pruritic eruption with oropharyngeal candidiasis. Diffuse tinea corporis and pityriasis rosea in a HIV patient. This is a eosinophilic folliculitis. This is a bilateral herpes zoster with cervical dermatome and disseminated zoster. This is a popular pruritic eruption with oropharyngeal candidiasis, diffuse oropharyngeal candidiasis, and hyperpigmentation post-inflammatory oropharyngeal candidiasis, cirrhosis, and radiculitis. Recalcitrant tinea corporis. This is eosinophilic folliculitis with oropharyngeal candidiasis. This is a leprosy patient with a diffuse tinea corporis. So, as a conclusion, dermatologic manifestations have a predictive value on cd4 cell count in HIV/AIDS patients, especially atypical, recurrent, widespread, unusual predilection, recalcitrant to treatment, and having more than one dermatologic manifestation in one patient. In limited health facilities with difficulty of cd4 count, skin examination can be an important tool for assessing the immune status.